Thank you. Actually, I forgot to thank Medtronic the last time I spoke, and Suntiravan. Thank you very much for your support and hospitality. I was asked to talk about nutritional complications. Now, this study I did to prove to myself if there are any nutritional complications after SADS, because if there is, we shouldn't be doing them. So we've spoken about all this. I'll just skip through that. So nutritional outcomes, whenever we do a bypass, the starting of optimization of nutrition comes before the operation, not after the operation, because you'll be surprised. People have so many deficiencies pre-op, and then you do any operation, it just worsens it. So you've got to make sure that you look for deficiencies pre-op and optimize them post-op. Now, whenever I try to embark on a journey with my patient about the SADS, there are a few things that I ask of them. And if they can't do that, I don't do a SADS on them. So the first thing is that they should take at least 80 to 100 grams of protein every day for the rest of their life. Now, they will not be able to get all of this in the solid form. We do a sleeve for all our patients, whether they are Thailand, Asia, America, India, Australia. The size of the sleeve is standard. Now, with that sleeve, if you try to ask them to take 80 to 100 grams of protein, they will be forever refluxing, forever vomiting, and they'll be blowing their sleeve out and coming out with weight regain. So with the sleeve, we say 40 to 60%, and it's usually 50% at the end of 1 year. If they are taking any more than that, you bet they'll come back to see you again for weight regain, right? So it's the same with the SADS. We ask them to take 80 to 100 grams of protein every day for the rest of their lives. Most of it will come in protein supplementation. The second thing is to take their vitamins and calcium for the rest of their lives. The third thing is they must follow up with us for at least 5 years. If they cannot follow up with us, they're not going to get a bypass, and it's not just the SADS. And the last thing is they have to do a bone density test once in every 5 years. I don't know about Prof. Torres, but if people don't take their calcium properly, they require about 2.4 grams every day. And if they don't do that, the body starts taking that from the bones. And it's only a matter of time they end up, getting osteoporosis. So you must do all of this. If the patient does not agree to all these things, they just get a sleeve and not the SADS. Yeah? So you must screen for deficiencies. And there's a very nice paper. This is from the US. Despite active recall of patients, only 30% of patients follow up with their surgeon, and that's at the end of 1 year, and we are talking about 5 years, right? So pre-op screening, just look at this. This is the ASMBS findings. It's just ridiculous, and the most common stuff in obese patients is folic acid, iron, vitamin D, and calcium, right? And if you are subjecting people to have the SADS or even the proximal DJ, if people don't have vitamin D and calcium, they are going to end up osteoporotic. Now, vitamin K is special. We need to check, because it's a fat-soluble vitamin, we've got to make sure that they're not deficient. Now, the monitoring of vitamin K is usually through prothrombin and INR, because to find vitamin K dependent factors to test for actual vitamin K is very difficult. In Australia, there is only one lab that does it. So to send the blood and get it back is about $300. So we just do prothrombin and INR. So these are the recommendations for the BPDDS. Why am I showing you this? In my country, we are quite backwards in terms of getting vitamins and supplements for our patients, because Australia is basically a gastric band country. They were doing bands, and bands. So they were putting one band, removing one band, putting another band, removing one band. So when people started doing the sleeves, there was some generic brand that they used to give, and they say 2 tablets every day. And now when certain people of ours who started doing the bypasses, they just started saying 3 of the same medication for a day. Now, different surgeries require the same vitamins in different strengths. So this was what was there for BPDDS. And this is the repletion recommendation, is that when a patient comes with a deficiency, it needs to be tailored supplementation based on the severity and the route of administration, right? So now coming to the actual crux. This is Professor Torres's paper. Now he has spoken a little bit about it already. Now the problem with, apologies, Prof, that you cannot, you see there is a lot of deficiencies here, right? Despite supplementation. But majority of his patients had a limb length of 200 and then 99, and only 15 cases. So to infer from this that, doing a SADS at 300 centimeters, people will have the same deficiencies was going to be a problem. But what you have to commend Prof. Torres is look at the incidence of follow-ups there. This is impossible in Australia or any other country in the world, and I don't know how you do it. 84% at 5 years, 75% at 10 years. How do you follow them up? That's absolutely amazing. Now, Dan Cottam did a 5-year follow-up rate at 21%. Now, that is more realistic in the real world. And he just said that compared to baseline, iron, vitamins B1 and D improved, whereas calcium, albumin, and vitamin E worsened significantly. He did not quantify any of this, right? Now, what do I do in my practice? Now, I would not operate on a patient if I wasn't sure of taking care of them holistically. There was no vitamins available. We tried to get the American vitamins. The TGA didn't allow us. But what the TGA did, that it gave me permission to commercially compound the vitamins, and they would supply all the stuff. So the monthly cost of these vitamins was then $30, which is, is about 24 US dollars. And even in the US, they don't get that. Now, I followed the standard American guidelines, ASMBS guidelines for repletion. This is what they said would be required for a BPDDS. And I thought that in BPDDS, the common channel is 100. We have a 300 centimeter common channel, so the vitamin A loss should be 1/3 less. So I then started giving them beta carotene, and we converted it through the international unit. Beta carotene is the bioavailable substance precursor of vitamin A in your body, and if there is vitamin A deficiency, the beta carotene gets converted to vitamin A. So, and then currently I have changed to 5,000 because this was a conversion error. So within a month we just changed it, so I had to report that. But everything else is what the American ASMBS guidelines tell us. So those were 196, and my follow-up despite COVID at the 3rd year, 4th year was not too bad actually. So from 78% came down to about 60%. So we automated. So I am, a private practice where we don't have a lot of registrars, we don't have a lot of colleagues to collect it or students. So I decided to use automated intelligence, and we started getting data from the labs, put it in a repository, and we were, just, it comes as a real line. Even now, if I want to see how my patients are doing. So this is how every day I can see how my patients are doing. So if you look at the BMI, most patients will drop. With this SADI, people lose 60 to 80% of their excess body weight at the end of 1 year. That's the most that happens. And then it goes on for about 18 months where they go up to 90 to 100% excess body weight. And at the end of 2 years, they put on a little bit. At the end of 3 years, they put on a little bit. And they stabilize at the end of 4 years, 5 years. And that signifies the intestinal adaptation mode. So that's that. Now, protein status. Now, the graphs that I'm showing, if you look at the numbers, every graph that I have, the numbers are actually within normal limits. The range is actually within normal limits. So with the protein status, you'll find that from 45.5, they drop down to, I think it's 11 or whatever the number is. And then that's at 18 months. And then it goes up at the end of 2 years and then stabilizes at the end of 4 years. So this is, it's an average, what we've taken. There are people that lie to the left and to the right. And the same thing is happening there with total protein. With the iron, now this is again normal range, but they were going down, 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 down. Still at the 4 years, they were going down, but still within normal range. That goes to show that you've got to really work hard on maintaining iron levels with these patients. Fat-soluble vitamins A, D, E, K, you can see the same. Now, why is vitamin D high? Australia, 80% of the population is vitamin D deficient before you start, right? So we pump them up. So that's why the number's gone up there. And then when we do the SADI, the numbers start coming down. And the vitamin D needs to be worked upon a lot in our country because it's sun, there's no UV protection layer. We get a lot of skin cancers. That's why it's low. So the E and K, you can see the INR is also beginning to, so you'll see the same pattern everywhere. As soon as you operate, within the first 18 months, boom, it comes down and then stabilizes, and then there is intestinal adaptation. Same about calcium and PTH. Vitamin B12, folic acid. You see they're in all normal ranges, comes down and then goes up again. The trace elements. It's very important to see zinc, copper, selenium, and measure all these because the deficiencies will cause subtle symptoms which you can't put your hands on, and the patient will be complaining of stuff and you don't know what the hell is wrong with them. So my malnourishment data, look at the amount of pre-op deficiencies that I have in these patients even before I start operating on them. The most subtle vitamin deficiency that will come first if your patients are not taking their vitamins properly is folic acid. You will find that folic acid, if it's going down, you just call your patients and ask them, hey, are you taking your vitamins? And the answer will be no. Post-operatively, we found mild to moderate deficiency in about 8 patients out of the 196, which is 14.2% for the first 18 months. However, at 4 years, we had absolutely no deficiencies. There was no long-term complications. I am yet to reverse or convert any one of my SADs, and thank God I've got no deaths. So these were the breakdown. Vitamin A, folic acid. Vitamin A is a little bit tricky because the regimen of replenishing them with oral versus injection is a little bit different, but we can discuss that later if people are interested. So it's just the breakdown of, because the supplement was altered 3 times, why people were getting them. So factors contributing to the favorable nutrition outcomes with SADI at 4 years is pre-operative and post-operative early and aggressive correction of their deficiencies, regular lab monitoring and follow-ups with the multidisciplinary team, and adherence to the vitamins that we give them. Whatever vitamins you have here in Thailand, if you make sure that they are having everything that is there in the recommendations. And at the end of the day, it is the responsibility of the surgeon and his team. If we think that these people with the bypasses are left in the community and they will take care of themselves, it is never going to happen. Whether it's a Roux-en-Y, proximal DJB, distal DJB, SADS, whatever you do, everybody is going to have nutritional complication of some vitamin or the other, depending on what bypass you do. Thank you.
Thank you, Professor Ravi Rao, for